Good morning, everyone. I'm Peter Boland, and welcome back to the podcast, More Health, Less Healthcare. Today, what I'd like to try and do is delve into this remarkable achievement of a whole lot of healthcare professionals came together to create this book. And it looks at it, and it's a very large book, it's 665 pages. I can't possibly do justice to it in one sitting, so what I'm going to try and do over the next three podcasts is take a look at the first third of the book. There are three sections: healthcare delivery systems, health plans, and then community organizations. What I'd like to do is maybe just focus on some of the high points that will probably catch your attention. And it certainly has been a tremendous privilege for me to work with maybe dozens and dozens of organizations around the country and really some phenomenal leaders. And if I can summarize maybe one learning that I take from this, that's the through line of all the different takeaways and lessons learned, is that every one of these organizations is really committed to better health and more health generation, not just to reduce sickness care. Both are absolutely necessary. And what they're really committed to is removing the barriers to better care and health generation. And that means a very, very serious focus on root cause analysis and prevention. And as we shift more of the resources into prevention, we're going to, over time, reduce the cost and the economic burden to society. So I want to just begin and say that currently, our healthcare, or trillions of dollars of healthcare spend, really breaks down into two categories. 97% goes to sickness care, and what gets left over, 2 to 3%, goes to prevention and early detection and maintenance. And realistically, it's the Einstein adage: if you keep doing the same thing over and over again and expecting the same results, well, that's the definition of insanity. I'd say maybe let's check with reality on this. If we're overemphasizing sickness care and we're shortchanging investment in prevention, investment in social health infrastructure, there is no way to turn around the spend, both the spend and the accelerating poorer and poorer health on a population-wide basis. So what I want to point out is that as we look at two trends that have come together in this decade, we have more and more chronic conditions per individual and more of an aging society. And you put these two trends together and then add into that new emphasis on metabolic syndrome and conditions. What we have is a lot of momentum that I would call a coming tsunami in the healthcare system, that the healthcare system simply is not capable. It simply can't deal with the level of chronic care that is overtaking the healthcare system. And if we look analytically, where the breadcrumbs are and where the trend lines go, we spend about close to 90% of all our spend in just the last few months of life. So clearly doing more of the same is going to get us the same results. So what I think the underlying theme of this book really does is that, look, let's take a look at where we've been, where we're going, and what do we have to do to get to where we need to be. So what I want to suggest to everybody is, if you have the patience to read this book, and if you don't have the patience, I'm going to outline it for you. But what I want to suggest is that we take a very cold, hard look. You look at the numbers, you look at the analytics, and it's very, very clear we're heading for a fiscal cliff. And it has just horrendous consequences right across the board. And one of the more and more realistic based assessments is that if you look at all our healthcare transactions, hundreds of thousands of transactions a day and per week, per month, roughly somewhere between 30 and 40% of those transactions, those procedures, have no clinical benefit to patients or society. And there are a lot of names that we can describe this phenomena. It's certainly waste. One of my favorite ones is suboptimal care, and probably the best one is low value care. It's all of those. Let's just call it waste. And to the extent that we can reduce waste, which benefits no one, to the extent that we can reduce waste And I think reducing waste should be job one of every C-suite in the country. To the extent that we can reduce waste, we have to begin to understand what's driving the waste. And here we get back into how managed care has developed over the last 50 years. And I really have a very strong view on this, is that the reality is that fee for service, which encourages procedures and procedure-based reimbursement, that fee for service is an evolutionary dead end. And that we're going to have to begin to look at what are the harms created by procedure-based payment, social harms, healthcare, unaffordable healthcare is a harm borne by patients and by society. If we look at what does the fee-for-service and the current system focus on, we have to begin to understand how do we push forward harm reduction. And this gets back into what I would call the reality of a different mindset, a different way of looking at these procedures and this volume and what constitutes better care and more care. I would have to say that every organization that I interviewed over the last few years are all dealing with the same agenda item. That's really trying to understand what's this new model, or at least a proposed different model of delivering healthcare based on health equity business concerns, health equity quality concerns, health equity access concerns. And if you take a look at what the underlying business model is, it's a set of policies and procedures that begins to reflect a different emphasis, a broader framework of how you can begin to design care systems and how you can begin to design reimbursement systems that shifts the balance, not to more and more volume, but to more and more focused care that I would call whole person care, patient-centered care, and with a heavy dose of investment in social health infrastructure. Without that investment, we are not going to change the momentum that's going in the wrong direction. So I think that each of these organizations are really grappling with what's the business model that we need to shift towards. And here we get back into rebalancing that 97%. And I'm not going to be so naive as to say we're going to just flip the script from 97% sickness care. And again, we have a sickness care system. It's not a healthcare system that generates health. And we're going to flip that to 97% in terms of prevention and health equity principles and programs. No, that's not going to happen. But we can begin to rebalance this over the next decade. And with this, I think what the handbook tries to emphasize is that there are dozens and dozens of organizations, not just in this handbook, but there are lots of other case studies as well that we can draw upon. But at least in terms of this handbook, what I have to say is that these best practices do, in fact, really indicate a way forward. These are thoughtful organizations, very much purpose-driven. And that's one of the other through lines. These organizations are purpose-driven, and their purpose is generate better and more health, not just for certain populations, but across the board. And so we aren't only talking about closing care gaps, absolutely critical, and looking at how do you begin to reconfigure the disparities in care, absolutely essential too. But it's a much bigger tent than that. It's a much bigger business model. So what we want to do over this podcast and the next two is try and articulate what the highlights are and how to basically summarize some of the best practices that you may be motivated to take a closer look at these case studies. So I want to start with three terrific case studies in the book: Boston Medical Center, Nationwide Children's, and University Hospital in Cleveland. Now, each of these terrific organizations are doing the right thing for the right reason, and they have very different strategies, different methodologies, different objectives, different goals, different benchmarks, and different impacts. But each one is dedicated to how do you treat the whole person where they are, and how do we put our arms around all these initiatives and really what I'm going to lay out is a lot of different initiatives. There is no one way to do it, right? Everybody's different. Every organization is different, and their goals and aspirations, their cultural leanings are different. So let's take a look at Boston Medical Center. That, anytime you're talking about social determinants of health or drivers of health, you have to go back to Boston Medical Center because they've been first mover for decades, decades. As I went through all their literature and talked to their staff members, what really become kind of clear to me is that one person is responsible for where they are today. And this goes back a number of years when Dr. Deborah Frank, a young physician, probably figured out that if we're trying to impact better clinical care, we're going to have to look at what impedes better clinical care. And she put the pieces together and found out that, well, the first thing you got to do is you have better nutrition, right? So she developed her instincts, and as patients would come in, young families were obviously, they were poor families who didn't have resources of fresh food and healthy food and nutrition. So she would open her drawer and bring out cans of different kinds of supplements, and rather not supplements, but different vegetables, etc. And that was really the genesis for their food pantry. And the food pantry today is, I think they give out some millions of pounds, over 1 million pounds per year. So it's gone from Deborah Frank's bottom drawer and canned vegetables to a very, very robust food first program. And they were the first to do food pantry. And they're enterprising. Where there's a will, there's a way. And they didn't have access to a community garden, so they started their own on the rooftops. And so when you go to the rooftops, they have 27 square uh, 27 square feet of rooftop gardens now. So aside from the food pantry and the food kitchen, which they then teach different families how to cook their own nutritious food, it's just a wonderful breakthrough on, do as we say, do as we teach. There are like 5 or 6 things that really stand out when I look at Boston Medical Center. They're absolutely patient first, patient centric. Now there's, have a lot of verbiage around patient centeredness and patient first. They do it. They design around each patient. The second, as I mentioned, they meet the patient where they are, right? And over, I think it's 37, 38% of their population, English is not their preferred language. So you have to meet culturally where they are, and that's cultural sensitivity and cultural competence. The third, which really struck me, is they're, I think, one of the first to really understand the absolute necessity of putting medical care together that features mental health as part of the wraparound. They've been doing this for a long time, but I think that we have to admit in the healthcare industry that we've kind of given short shrift to behavioral health. It's kind of been the stepchild for a number of decades. Now it's come out of the closet, and it's definitely part of what their care program is. The fourth is the medical legal assistance program. There is, I would call it a medical legal partnership. They're well aware of the impact of what the legal system, the justice system, has on individuals and their health and their stress level. It's a very creative program that's being adopted widely around the country now. And the fifth thing that absolutely jumps out is this notion of power sharing with the community. Now, what's the need for power sharing? Well, if you're dedicated to the community, you're trying to generate more health in the community, and you realize that the real expertise is not in the hospital, the expertise is in the community. They're the expert on what the problems are and what the solutions are. And once you recognize this, it leads you to say, well, we're going to have to basically get in bed with our community. And they've really done this, and it's just been a terrific example to try and follow in the last couple of years. And the last is violence prevention, whether it be interpersonal violence, street level violence, or environmental violence. You have to look at what the environmental context is of the patients, the families coming in for care. So whether it be food nutrition, and that's related to, I think they have 12 or 13 diagnostic areas. Food clinic is related to your diagnostic condition. And you can come in and visit the food pantry every 2 weeks. I think it's open I think you get 4 days worth of food every 2 weeks. And again, this is meeting the patient where they are, understanding their economic conditions, understanding what the resources are, and understanding what's available in the community. And Boston Medical Center, beginning with Dr. Frank again, some decades ago, they're really at the forefront of social determinants of care. And it's just an exemplar of an institution. Now, completely different is Nationwide Children's in Columbus, Ohio. They're a renowned pediatric center throughout the country, throughout the world. And what they had was, I think, maybe the most ambitious goal that I've come across in the last couple of years of all these studies. And Chris Weeks was on a podcast a couple of weeks ago, and he's the head of the Community Relations and Health Improvement Program. Just a wonderful interview. And he made this outrageous statement that what the institution is really, this is a pediatric institution, right? What their overall goal is, it's to have an intergenerational commitment to break the cycle of poverty and discrimination in the whole area. Now, this goes beyond any single focus of an SDOH initiative. They are trying to break the cycle of poverty, period, all across the board. So you have to begin with the communities nearest to your facility. And being a world-class facility, Nationwide Children's understand they want to enlarge their footprint, and that means interacting with their community. And they're well aware people. They understood that there's a backlog of distrust in the community based on historical discrimination, and they realized they're not going to succeed as an institution, and they're going to fall short in their aspiration unless they work hand in glove with the community. So they had a different approach too. They understood that if we're going to break the cycle of poverty, we're going to have to understand how to influence the economics of the immediate neighborhoods. What they devised is a housing first policy. Now, you can begin with food pantries, you can begin with housing. It doesn't matter where you begin. It's a matter of your own cultural preferences, what your organizational capacity is, and your ability to fund these initiatives. They made an intergenerational commitment. We're going to break the cycle of poverty, and we're going to put a stake in the ground that says we're going to be here for generations. So that led to housing first. And anybody who's put together the capital stack for a housing initiative, whether it be building from ground up or house rehabilitation or even rental assistance, you understand we're talking some millions of dollars. I think their initial capital stock was somewhere around $5 million. And they have now had dozens and dozens of housing starts and rental assistance programs. It's just been a tremendous success. But the point here is that if you're going to be in this game and you're going to really contribute, put a stake in the ground, we're talking a generation. We're not talking about quarterly earnings reports and end of the year summaries, because you can't get an ROI on a 10-year capital investment every year, right? It takes a number of years to understand what the economic and social impact is. So they put a stake in the ground. And what this basically said to me was that you can start with housing, but they have a 5-pronged program that break the cycle of poverty. You're talking about interventions in education, workforce development, community safety, and obviously health. They have now reached their first set of goals. And I then asked Chris, well, tell me more about some of the other programs that maybe aren't quite as big a ticket program. He said, well, if what our process is to treat the whole person, that's the whole family, then it becomes that's the whole community. So it's the community that is now our patient. So they took a look at what are all the ways we can help our community economically, socially. And one of the twists they came up, which I thought was just ingenious, they said, why don't we see if they have problems with their tax returns? And I said, Chris, what's the ROI in helping them with their tax returns? He said, well, in the first year, we help them fill out the forms. And if you're under $70,000 a year, you're eligible for our program. He says, we put $5 million back in their pocket this year because of this initiative. I got to thinking, what if every hospital in the country, as well as other social organizations, how many tens of millions of dollars could be back in these people's pockets? Now, I think one of the real keys to their success has been obviously commitment to the community, but how do you begin to understand what the community really wants and what they really need? And their CFO, this is a numbers guy, left his office, came out to the community. Over the couple of years, he went to dozens and dozens of community meetings. He met the leaders, he met the faith-based group, he met the small business owners. He became the emblematic leader of this initiative. That not leader in terms of articulating what the patient voice is, but he put himself out there saying, we are going to be part of your community. We're going to invest in you long-term, multi-generational. Can we collaborate? Can we partner together? And the answer was yes. And it takes that kind of initial, that kind of chutzpah, let's say, if we're going to raise $5-10 million of capital stacks and other programs, we're going to have to do it in collaboration with the community. So I don't know, are they going to be able to break the intergenerational cycle of poverty, let alone increase care, increase health generation? It looks like they're on track. They've made a tremendous, just in the last 2 or 3 years, their outputs and their benchmarks and their goals and objectives they've created are really, really inspiring. But it just goes to show every single hospital, every single delivery system is different, right? Again, no right or wrong, but what this book lays out is here are all the ways that others have done it. And here's the documentation for it. The last thing I want to touch on today is completely different. Cleveland Hospital, tertiary hospital, academic medical center, another world-class institution. And they have, I think, maybe the most straightforward initiative I've come across. It's a zero defect policy. It's not just about nutrition or housing, anything. Zero defects. We're a clinical institution. It's on us to engage in zero defect. What does this mean? And he was an enterprising physician that came on board, and he had a background. He was a MacArthur Genius Award grantee, and he had worked out a whole checklist system, much like airplane pilots and aviation does. He brought that to quality care, developed a reputation, came to this esteemed hospital, and what he brought with him is an idea of, all right, how do we implement a zero defect policy? Well, you have to get everybody on board. And again, how big an issue is that? Well, it's about $4 trillion a year. That's a big issue for everybody. And I'd have to say there's not a hospital in the country that doesn't have a defect issue, right? It's widespread. It's just part of the culture. So what he decided was we need a different kind of management system, different level of accountability. He brought what I would call a fractal management system, where every single layer of the organization, the whole bureaucracy, has to train one another in zero defect. That means everybody's going to be accountable, no matter where you are in the organization. Every touch point, every person that has a touch point with a patient has to go through this program, this training program, and they will be held accountable. Now, the really creative thing here is that if somebody screws up in the lab or somebody in the OR misses their next step, they're not just held accountable, but the people above them who trained them, they are accountable. And so what they did is they put a lot of financial and organizational incentives in place so that every single person has a role in this, and they track every single patient throughout the whole patient journey and every touch point and understand, did we do the right thing for the right reason right across the whole patient's journey? So you're probably wondering, well, how do they test this out? They got a cohort of patients, high need, high cost Medicare patients with diabetes, and looked at if we apply this fractal management system and put into play zero defect as our number one goal, as the means to better care and less cost. Will it work? Well, after the first year, 9% right off the top. Now, you're a multi-billion-dollar medical organization. And if you're looking at how to save money for upstream investment, and you can focus on zero defects, well, do the math. 9% of $1 million, do the math. You have an enormous amount of discretionary resources to then go upstream and invest in whatever social care infrastructure you think is important, and in conjunction with the surrounding community. So again, where there's a will, there's a way, but it takes courage. It's confronting our mindset and our lack of imagination that if we really want more care and better care and more health, then we're going to have to change how we look at our reality. So that's a change in mindset that I was very aware of as we put all these studies together. So what I want to conclude with, I'll just give a brief heads up on the next set of case studies I would like to look at. The next episode, we're going to look at Presbyterian Health in Albuquerque. I think they're now the largest employer in the state. Houston Methodist Hospital, and it's a terrific program. They came, I believe, first in the country in terms of care management and quality of care. And third is Cleveland Clinic, and then the Vanderbilt Health in Nashville. So I will highlight these in our next episode, and I'm just delighted again that the Healthcare Case Studies Handbook really is a guidepost for how we can learn about how to do it right and do it for the right reason. So thank you for tuning in, and we'll see you next episode.